This is a walkthrough and guide for transitioning the use of anesthesia machines into the ICU as ventilators if the need arises and there are not enough ventilators and you are overwhelmed with COVID-19 patients. These will be applicable to modern GE anesthesia type machines. Here we go. Some important disclaimers. Anesthesia machines are not meant to be used or never were designed to be used long term in the ICU as mechanical ventilators, so there's some key differences, which is the purpose for this overview. The suggestions and tips that are contained in this are not FDA approved at present in the pre-COVID-19 era, so there are some serious safety considerations if this is ever attempted. And an anesthesia clinician and a biomed tech should probably collaborate together before use. You should definitely test the setup before attaching it to a patient. Usually at this point it's becoming desperate, and if you're brought in at the last minute, definitely test your setup with a breathing apparatus just to make sure that any untoward patient events are avoided. And then most importantly at the end, make sure you return the configuration to normal when the machine comes back to the operating room, because we're talking about removing the scavenging apparatus. Okay, the high points. Check the Anesthesia Patient Safety Foundation COVID-19 resource page. For any current updates, they are very active in updating articles and resources there. Excellent. The ICU, PACU, and emergency room locations don't have the purple waste anesthetic gas pipeline for scavenging. So that's always present in the operating room. It's not present in the external locations. Any of the bag type scavenging systems, when they don't have active suction applied to it, create about 10 to 15 centimeters of water pressure of PEEP. And that happens after about 30 to 45 seconds under normal circumstances. And so the scavenger bag must be carefully removed. This is counterintuitive to most clinical practice as anesthesia clinicians. Viral filters also have to be used at the Y connection and the expiratory limb, as the exhausted gases will be going into the room, into the ICU or the ER, the PACU. And because they go into the room environment, we want to filter the viral particles as well. Humidity is not provided by the anesthesia machine like an ICU ventilator, so you'll typically have to account for that in the use in the ICU. All right, so if you get called into the operating room and they need an anesthesia machine to be brought up to an external environment, if you roll the anesthesia machine into an ICU room, these are the connections typically that you'll see. Notice there's no waste anesthetic gas connections like we have in the operating room. So as I said before, any of the bag type anesthesia machine scavenging devices must have the scavenger bag removed prior to patient use. The scavenging rate valve does not need to be adjusted if the bag is removed. If you leave the bag in place and you try to open the valve all the way, you can have as high as 15 centimeters of water pressure of PEEP, and there's no way to release it unless you disconnect the bag, even if the pin valve is maximally opened. A little word about viral filters. So in ICU ventilation, they are placing viral filters at the Y piece and at the expiratory limb, and they even are able to exhaust the exhaust gases on the other end of it. There's not going to be any way for you to do it on an anesthesia machine that way, because the size of the scavenger bag is deliberately made different than all of the other airway connections. So you could never mix them up. At our institution, viral filters must be used at the Y and the expiratory limb. And everything else, when the scavenger bag is disconnected, will go into the room environment. There are a couple of exceptions for where the viral filter gets placed in proximity to the sampling line. If you have an ASIS CS2 with software version 11, the sampling gases actually get put back into the breathing circuit, so we don't want to contaminate the machine. So you'll place the viral filter at the elbow prior to the sampling line. You'll see in the video. If the first filter becomes overwhelmed by secretions during the use, replace the entire circuit and both sets of viral filters. Machines where secretions overwhelm both filters in a COVID-19 patient should have the entire breathing system processed and sterilized prior to additional use on a non-COVID patient afterwards. All right, so viral filters, here's kind of what they look like. If you look at an ICU vent, you see how tiny this is in comparison to an anesthesia machine. They are set up at the expiratory limb and the Y, like we would use, but they have that additional connection on the exhaust that you can see there at the right. If the first filter again becomes overwhelmed by secretions, then you can, replace the entire circuit. Here's an example of what the HEPA filter looks like. As I said before, software version 11 returns the sample line to the circuit. The current APSF guidance advises using Biomed to convert the sample return to scavenging instead of back to the machine. That will protect the machine in all scenarios. If you're ever curious about what software version it is, the version is shown when you boot up the machine on the screen. And again, the advice on the APSF guidance in the resource is to place viral filters at the Y and the expiratory limb. Okay, so those are the high points just to review, but let's just get to the video so you can see how it actually happens. All right, so all you have to do, if you disconnect the scavenging hose, there's going to be a buildup of pressure. We tried it, opening up this valve all the way. There's still about 10 of PEEP when this is connected. So you're going to have to remove, if you have one of the bag type scavenging systems on your anesthesia machine, you'll have to disconnect it. And that's going to be all right because everything from the ventilator exhausts into the room. So what respiratory does is they place filters, both at these two connection points on the anesthesia circuit. We're used to being able to have, this is a viral filter, so it's down to 0.3 microns. Okay, it's written on the packaging if you have any questions. And then the other important part is we protect the machine in case the primary filter becomes overwhelmed with secretions. Okay, and then because we're going to be ventilating patients, really this is the scenario where you're trying to do this just for while you're waiting for an ICU ventilator to arrive or become available. You can use this type of setup in the meantime, and that'll buy you some time. So, just to prove that this all works for you, we're going to simulate the lungs here. So if you had to put a patient on, we'll go ahead and use our pretend lung here. We'll start a case. Start case now. This is for an ACES CS2. It also works on the Avance CS2 and also on the CareStation 650. So here we go. I'll set some tidal volumes, a lot of PEEP here. Okay, so it's going. And there we go. So here's our lungs. It's going. And the key concern here is we want to make sure that we've disconnected the scavenger bag as well as the scavenger. We filtered on both sides, so it's not introducing any undue resistance to the circuit. And you can see we're generating 24 centimeters of water pressure here, 8 of PEEP as dialed in. It's not overpressurizing, okay? So that's how, this is our proof of concept. If you find yourself in austere circumstances and you had to use an ICU ventilator, the first gotcha that you'll figure out is that, number one, there's no waste gas or scavenging pipeline to be able to hook that up to. The second thing that you'll find out is that by disconnecting the scavenging bag, you'll be able to maintain any normalization of PEEP as we've decided here. Another thing that is a main difference between anesthesia machines and ICU ventilators is that they have the ability to introduce humidity. And we, in anesthesia, do that naturally by lowering the flow rate from, like, say, 10 liters down to, say, 1 liter or so. So that's what we're doing here. But that's our realm. Respiratory therapists, pulmonologists, intensivists don't think about that. They're used to the machine providing that type of humidification. It's for that reason that you still have to have an HMEF in line and try to remember that we're going to try to use lower flows. Okay? Again, this is just to kind of buy us time. We're just doing cases for 2 to 3 hours, sometimes 8 hours, but not 24, 48, 72 hours. So that's a consideration that you'll need to keep in mind. Thanks. So if you find yourself in a situation where you have no ability, like you don't have one of these fancy Y connectors to connect to suction, what happens if you don't? You'll get an alarm on the 650, but just make sure that the scavenger valve is maximally open to air. And so all of the exhaust gases from the ventilator will come out through this scavenger. So keeping in line with our suggestions before to make sure you put a HEPA filter both at the Y and on the expiratory limb, which is this one on a GE machine. And then you'll get an alarm that says the scavenging is too low, but that's all right. You'll notice here that the PEEP is not building up in our little, practice compliance lung here. Okay? All right, so that's one other option. So as part of the review of other types of equipment, just a quick little note and variation. If you happen to be using a CareStation 650 that does not have a balloon-based scavenging system, so if you kind of walk along with me over here, to this side you'll notice that we've got our Y set up to the medical grade vacuum, and that if you were to twist the valve on the scavenger all the way closed, you get a nice little notice that the scavenging flow is too low. So given the fact that you have normal high suction on that, we figured out that's about 2.5 rotations. So here we go, 1/2, 2/2, and then right there, it should go away. That's the sweet spot. See? Too much, too little, just right.